Well, welcome to Seattle, Washington and the University of Washington. We're so honored to have this opportunity to present a live case for TCT. Thanks so much for inviting us. My name is Jamie McCabe. I'm an interventional cardiologist here. I'm joined by wonderful colleagues and friends, Gabriel Aldea, head of CT surgery, Burkhard Mackensen, who's going to be our imager and is the chief of all of anesthesia, Christine Chung, interventional cardiologist, Greg Kondos, our structural heart fellow, Alyssa, the technician. We've got Megan and Adam, representatives from various companies. We've got Chris, our nurse. Injun, our CRNA, is hiding back there. So really honored and excited to be here. Why don't we jump right into the slides and talk a little bit about the case we have prepared for today. Greg, take it away.
Great, thanks, Jamie. So our patient is an 84-year-old female with class 3 heart failure symptoms who has severe MAC and severe mixed mitral valve disease. She's referred for mitral valve replacement. So you can see she has a prior history of calcific aortic stenosis, status post-TAVR, earlier this year in February. She also has a history of high-grade AV block and had a pacemaker placed last December. She otherwise has medical problems to include peripheral vascular disease, mild renal dysfunction, as well as type 2 diabetes. She has an STS score of 10.5% for mitral valve replacement. On echo, you can see here her mixed mitral valve disease with heavy MAC. She has severe MS with a mean gradient of about 11 millimeters mercury at a heart rate of 72, as well as moderate mitral regurgitation. Next slide, please. She had an angiogram done late last year and had no significant coronary disease. And so on her preoperative CAT scan, you can see here that she has very heavy annular calcification that is nearly circumferential in nature. As far as her annular dimensions, she has a com-to-com dimension of about 39 to 40 millimeters and an AP dimension of 28 millimeters with an area of nearly 900 millimeters squared. Her initial neoLVOT was estimated at about 240 millimeters squared, but had a prominent knuckle. And given the large mitral annular size, we elected to initially try to enroll her in ENCIRCLE. Unfortunately, due to concerns of LVOT obstruction, she initially screen failed. We therefore, next slide please, decided to proceed with Sesame septal modification in an effort to make her a better candidate. Here are a couple of representative fluoro shots from the Sesame procedure, which was performed in June. You can see on the left screen, there is the wire and microcatheter traversing the basal septum through that prominent septal knuckle and exiting in the mid-LV cavity. And then on the right side, after snaring of the wire, externalization of the wire, and formation of the flying V, that wire is electrified and pulled through to create a laceration in the basal septum. So following the Sesame, you can see on the left that we have expanded our estimated neoLVOT. We picked up over 200 millimeters squared of neoLVOT size. And then as you can see, as we're scrolling through on the right image, as you come down through the aortic valve, you can see that that splay is located in continuity with the aortic valve, thereby increasing that LVOT outflow. Unfortunately, at this point, we resubmitted her, and due to some diameter restrictions on the inclusion criteria, she again screen failed for ENCIRCLE.
Yeah, so this is obviously a challenging scenario. We now have presumably no issues with outflow tract obstruction post-Sesame. We got over 200 square millimeters from our Sesame gully, but we still have a valve area over 900 millimeter squared. And so now that ENCIRCLE is off the table for us, and we took it to our friends at DASI Simulations to sort of look at how the valve might fit in there. And it fits well, but they did identify gullies on both sides. And my read of the left-hand picture is that we are only extending the MAC on the kind of anterior leaflet. There's not a lot of compression medial lateral, which of course is what you'd expect given the com-to-com distance of 39 to 40 millimeters. So we have had some experience with this in the past, and obviously this is not our first move. We'd rather have people in dedicated trials, but it's not always feasible. And so what we've done to sort of address this is, if you hop to the next slide, is we sort of mix and match technologies a little bit. Something that we used to call Anchor, and now we're calling the artist formerly known as Anchor, now called Arctic, where we essentially put in a clip to close off either the medial, preferably, or the lateral commissure to shorten the com-to-com distance and help with anchoring and chance of paravalvular leak. And this is something that we do simultaneously, and we have some experience doing that, and that's what we have planned for you today. We're going to perform an Arctic TMVR. Lampoon is not required because of the big outflow tract. Burkhard, you want to take us through the echo findings so far?
Sure. So you already saw some of the images, the past history for this patient, but here's some live images from today. Again, the en-face view with the significant MAC and leaflet calcification. If we look from ventricular side up, again, we see a very small opening for that particular valve. And then we went into some multiplanar imaging just to find out where we could possibly best find an opportunity for a TEER edge-to-edge repair, starting in the middle and then going more medially as opposed to more lateral, as you see on this image. Again, we found probably the best opportunity in more what looks like a lateral commissure. As you see here, the red plane actually indicates the optimal orientation for the TEER device, in this case a MitraClip. And then the right upper image is a long axis view, again with a good rotation of the planes to mimic the perpendicularity for the clip.
So a couple of salient points here as I bring the clip up. One is that when we do these Arctic procedures, I certainly prefer to clip the medial commissure, because the valve, as you stand it up later, as we'll see, the valve routinely lies on the posterior commissure. So to the extent that you can get everything on the clip on the medial commissure, then they don't interact before you're ready. But you have to go where the tissues are healthiest, so it is what it is. The other thing to note is that in these procedures, the position of the transeptal is meaningful. You want a lot of height, obviously, for your MitraClip, particularly if you're going for the medial commissure, but by the same token, a lot of height for a TMVR is not perfect. So you end up with a bit of a compromised position. Posterior is very important, but you may not go quite as high, and that just sort of helps you deliver the valve prosthesis after you're done with the clip, obviously. So we're just going to get a little bit of alignment. I know that I'm on the medial side there. I'm going to fix that in a second.
Starting to, again, mimic the perpendicularity in the red plane.
Yep. Push in a little bit. Okay, let's check our grippers here. Go ahead.
This is button. That looks anterior.
Yep.
Posterior, I didn't see as clearly.
Yeah, so just drop the lock and then do it again. Okay, very good. Yeah, okay. Terrific. So I'm obviously very commissural there, which is, generally what we want here, is to eat up that area. It is so calcified that you do usually go down closed. I think we're okay, and I look like I'm tracing in the NPR, obviously the shaft of the system, just you want it to trace both the red and the green lines in the upper boxes, and once you have that, your dive should be okay. Good if I come down, or am I
think you're still a little bit too commissural at this point.
Commissural. All right, let me pull back here a little bit and a little less anterior.
Perfect.
That's maybe too much, huh?
Maybe just a hair too much.
Yeah, go forward, just there. All right, let's Let's just
Yeah,
check.
that looks like a good spot to come in.
Yeah, and let me just check my angle again. A little more clock, perhaps. Okay, something like that.
Yep,
All right,
that's good.
coming down. Diving centrally, so I'm going to take some M off. If I can. It's also possible the calcium's just pushing me over there. If I pull back and take a little more M off, maybe I can get it to sit better. So trying to just get under the leaflets and then open up there just to less chance for entangling everything. What do you think of my position here before I open too much?
Let's look at the on fuss. I'm going to gain down as you open up.
So a little clock.
Yeah.
Okay. I'm going to push in a little bit and go a little anterior. Will bring me up that commissure. There you go. Okay.
Okay, I'm going to go back to 2D.
This is an NTW clip. I can't remember if I said that already or not. But just something.
Let me optimize my plane on the left side.
Okay. I'm just coming up. There's so much calcium shelf there that I presume I'm just going to feel it when I hit it. It's about there. It's just pulled the whole system down with it. Let's close this down a little bit.
So I do see the anterior leaflet better now.
Yep. So they're both dropped. Give you a second to take a look there.
There.
Well, that's a nice view.
That's good.
Yeah,
So I see the clip arms better now.
Yes, me too. I think they're both in.
Yeah. And the grippers are up currently?
Grippers are down.
Okay.
And then here's lock, and if we close slowly.
Yeah, I'm going to stay here. That's a good plane.
Hard to tell with that anterior leaflet, but
Yeah.
certainly the posterior is in.
Here's another 3D. Posterior, I think we have no question. And I think here's an anterior bridge too, right?
I think so. And we nicely ate up that, that lateral side, so that's great.
Yeah. Gonna add color one more time. Maybe go to 1 beat for the color. Yeah, we've certainly pushed the color all the way over to the right side there.
Yeah. I think we're good here. So it's obviously a little bit of a leap of faith to let these clips go because they're not always as convincing as in a standard MitraClip, but I think we have evidence of a tissue bridge. We have no color coming in over there. There's a little dropout behind there deep in the commissure, but that's all right. And I think we accomplished what we wanted to, which was to close down a little bit of that lateral side, shorten the valve a bit, make this a little bit more reasonable sizing for a valve in Mac. Would you agree, everybody?
Yes.
Yes.
Okay. All right. So one question that could reasonably be asked is whether or not you would just leave the clip for a month or something and let it scar in before you came back for the TMVR. And I guess I'd just say that in the Pacific Northwest, people travel from really far. And also in some really bad valves, putting a clip in drives the gradient into something pretty intolerable. So we largely haven't done that. Clip's released and looks fine. We largely haven't done that, and we've done it simultaneously, and that's a financial decision that has to be made. as an institution and so forth. But let me take that.
Mhm.
But that certainly in terms of safety and procedural performance, it has not been an issue yet, and I shouldn't say that right now, but it has not been an issue yet. Oh, this is what I was saying.
No.
So you see here, there's a new figure 8,
Yeah.
the small ostium laterally.
So let's take a look at our angle. We'll mag in here a bit. So there is clear parallax in the valve. As we come, I think it's going to be about there,
Mhm.
which is roughly what we had kind of originally planned for. Okay. Okay. Can we have the Safari, please?
Mhm. Yep.
So we'll bring in this wire. So this is just an example of how everything kind of hugs that lateral commissure, which is fine, but obviously you'd rather not have everything bang into that clip before we really get going, and which is why I prefer it on the medial side, but you get what you get.
Mhm.
All right, you got the wire?
Yep. Got it.
So we'll do a septostomy now. We're using a 14 millimeter balloon. You could probably use something smaller, but we like a 12. Some people use a 10. I don't know. I think you might as well make this part of the procedure easy. Go ahead. And because we routinely close the septum anyway, you got it there. Not sure it makes a huge difference what size you use. Yeah. She's got quite a lipomatous septum, so we're really counting on this not having too much recoil. One more time, please. Okay. Okay. And that's down. And we'll just lock this back in a
All
second.
the way down.
And then you can just lock it so you don't have to hold it. Okay, and then we're otherwise ready for the valve. So we do have a 26 French sheath in, which I like for the TMVRs. That said, we're not mounting on balloon here, mostly because we've had some issues in the past with mounting on balloon and crimping too hard, perhaps, and crushing the balloon like insufflation system. So we still mount in the IVC, which I think is fine. The nice thing about a 26 here is that once you're mounted, if you can't get across the septum, you have the opportunity to take the valve out without taking the sheath out, and that is different than if you were to just use an E-sheath. So I think that is a real advantage. We can also start to mount the valve kind of in the sheath so we don't have...
Coming back?
Yep, go ahead. I'll slowly come out as you come back. Yep. Okay. Very good. Thank you. So we're going to turn the handle of this E-sheath over. A little negative on that wire, please. A little more negative. More negative. Okay. Very good. We're getting kind of tangled up with all the leads there, but I think it's okay. All right, that went over pretty nicely. So now, I mean, it's such a shame that you can't leave the pusher where it is, because these are scenarios where With the pusher in place, the parallax is quite good. Then you pull the pusher back, and the parallax changes. I got the wire. Well, this is going to be all right. So I'm going to unbend the pusher a little bit, just to stand it up a little bit more, and then I've got my fingers on the wire and on the push catheter, so I can try and stand it up. We call the push-push, to get it to stand as centrally as possible. I think that looks pretty good, Burkhard. What do you think?
Yeah, nice and vertical in your approach.
Okay, so let's get going because we do have slightly low blood pressure. Yeah, meg up to 10, please. And then let's pace at 200. Okay, we don't have to hold respirations. So go ahead on. Okay, nice and slow. I'm going in a little bit. Okay, go ahead. Yeah. I like that. Yeah. Uh-huh. Keep going. Beauty.
And
And pacer off. Okay. All right, let's resuscitate for a sec. Hold on, we need to get more fluid out of this balloon, which is in the middle of the... give me a sec. Let's get this out of here. Yeah. Okay. Okay, good. So we'll just pull this back, give her a second. Blood pressure's coming up. We just were occlusive on the valve for a minute. All right, let's push her back. Let's mag out. Very good. So now we can walk this back, please, and then we'll take the steerable guide back and the pigtail, or balloon wedge, whatever you got. Push the wire forward. Almost. Okay, very good, got it. What do you think, Burkhard?
Well, the orientation and atrial versus ventricular looks great. At this point, the valve looks stable. I still see the clip to the side on the lateral. And then with 2D color, actually looked very good already.
Okay.
I don't have a 3D color yet. I'm going to get there in a moment.
Let's get, we'll get the stiffer wire out, and then
you
should have a better assessment.
And the blood pressure has nicely recovered, as you see.
Yeah. Lock that out. Obviously, the clip and valve complex are quite stable. They are, dare I say, chill. That's an Arctic joke. So nothing across the valve at the moment.
Okay. And I don't see any obvious PVL or flow around the valve.
Looks pretty beautiful, really.
Can we hold the vent for one moment? Just going to add a couple beats here to get a better assessment.
No post-ablation either.
No. All right, and after you capture that, we'll recross the valve and get some hemos.
Beautiful.
So there's AOLV, no outflow tract gradient, obviously, which is terrific. Okay, thank you. And then we'll switch AO to LA. Mitral gradient looks like nothing here as well.
The blue indicative of the diastolic forward flow and no significant regurg and nothing around the valve, importantly. And then I think it's also important to, one more time, we know the gradients across the LVOT, but it's good to kind of look at the LVOT and place some color Doppler in there and make sure there's no significant turbulence. Again, shadowing there, but you see the laminar flow in red.
Yeah, nice flow around through that sesame and into there. And then pulmonary veins are now normalized.
They're normalized. I can show them briefly. Here is one of them. That's the
Well, that's
left, and I can also get to the right real quick. Here's the color, and then adding it's all red forward flow. Here's the signal.
that's terrific. We're done. And on fluoro, just to show what things look like, here we'll mag in a little bit. Always kind of fun. There's the clip and the valve together, and if we go to a kind of an L caudal view, usually we can see the down the barrel sort of look. See if I can find that for you. All right, and so here's your down the barrel view showing that clip on that lateral commissure, nicely just bracketing everything, giving us a little extra buttress. I think that looks great. So I'm happy. Any issues anyone sees? Let's take an exchange length wire, please. Okie dokie. So to wrap up, first off, I want to acknowledge that we have an incredible team here of people where we need all of their talents to make this work, right? We have to have a superb imager to try and grab leaflets in the commissure. We have to have talented and dedicated surgeons who have been in this and with us for the whole time, not just today, but over the years, so that the cadence and the sort of a lot of operational things can happen without having to over communicate, given how many people are in the room. Without having amazing colleagues who can support you, put another set of eyes on things, be one step ahead of where you are at all times. Those are really essential tools, and I'm incredibly lucky to have this set of people with me as my partners. This is a case where it's a patient who was very symptomatic, who's really been longing to have her mitral valve fixed. We did our best to get her into a dedicated trial. Given her large annulus size, that wasn't feasible. So we adapted and we accommodated for that using this Arctic technique, which allows us to shorten the intercommissural length of the valve such that we get a really nice seal and we get a really nice anchoring of a commercial sapien valve in a mitral annulus that was over 900 centimeters squared to start. So as you saw at the end, we've got no paravalvular leak. We've got a mean mitral gradient of 2. We have no outflow tract gradient, laminar flow there, and normal pulmonary veins. So I think we're really happy with how this went. So thankful to be allowed to show this case for TCT, and I look forward to seeing everyone there. Thank you very much.